Welcome to my class, and today we are going to learn the section 3 of the diseases of the breast. Today's lesson includes the benign breast diseases and sarcoma of the breast. The first kind of disease we call multiple nipple and multiple breast deformity. The absence of breast tissue and absence of the nipple are rare, but supernumerary nipples are usually rudimentary and occur along the milk line from the axilla to the pubis in both male and females. They may be mistaken for a small mole. However, accessory nipples are usually only removed for cosmetic reasons. Accessory breast tissues is commonly located above the breast in the axilla. Rudimentary nipple development may be present, and lactation is possible with more complete development. Accessory breast tissue may be seen as an enlargement mass in the axilla during pregnancy and persists as excess tissue in the axilla after lactation is completed. This picture showed axilla accessory breast tissues. And in this slide, I will introduce the mastitis. Mastitis is a common disease during lactation. And there are also non-lactational infections. We don't call it mastitis. They are more complicated diseases, and we are not going to mention it today. The lactation infections are thought to arise from entering of bacteria through the nipple into the duct system, and the main clinical manifestations is fever, leukocytosis, erythema, and tenderness. And finally, the abscess is formed as the picture showed. Infections are most often caused by Staphylococcus aureus and may be manifested as cellulitis with breast parenchymal inflammation and swelling. The treatment requires antibiotics and the surgical drainage or puncture drainage of the abscess. And we are going to introduce the other benign disease called mastopathy. It is the mammary disease. And they have a new name called Fabrocystic Change and breast pain. Mammographically, fabrocystic changes are usually seen as diffuse or focal radiologically dense tissues. By ultrasound, cysts exist in up to 1/3 of all women over 35 to 50 years of age. And this kind of disease is very common during the 4th and the 5th decades of life and will last until menopause. After menopause, this kind of disease will relieved. That might be because of an exaggerated response of breast stroma and epithelium to a variety of circulating and locally produced hormones and growth factors. It is very troublesome because it will cause periodically of breast pain, tenderness, and nodularity related to menstruation, which make a lot of patients very anxious. But fabrocystic change is not itself a risk factor for the development of breast malignancy, unless with the high-risk proliferative disease as a typical ductal hyperplasia or a typical lobular hyperplasia. And in this slide, I will introduce the most important benign tumors in breast, the fibroadenoma. It is the most common benign tumor in the breast, which is the most common tumor in women younger than 30 years. It is benign, solid tumors composed of stroma and epithelium elements. The clinical manifestations is firm, movable, smooth or lobulated, slow growth mass with circumscribed border. When palpation, you can feel the mass very easily split away under your finger. And the treatment of the fibroadenoma, unfortunately, there is not effective medication. The excision is the only curative method, especially for the giant fibroadenoma, which is over 5 centimeters in diameter, or juvenile fibroadenoma, which refers to the occasional large fibroadenoma that occurs in adolescent and young adults, and histologically is more cellular than the urofibroadenoma. And those may display remarkably rapid growth, and surgical removal is required. Fibroma, in general, fibroadenoma are benign tumors, although neoplasia may develop in the epithelial elements within them. But cancer in the newly discovered fibroadenoma is exceedingly rare, very rare. And this picture showed a section of a fibroadenoma. You can see the lobulated structure, very good border, the fibrous capsule around it. In the middle, it is a mammography. Mammography is of little help in discriminating between cysts and fibroadenomas. They both have very clear border and equal or lower density. However, the ultrasonography can readily distinguish between them because each has specific characteristics. You can see very clear border, the capsule echo, the enhanced capsule echoes, and there is a lower echoes inside of the tumor. The other benign tumors are papillomas and papillomatosis. In my opinion, this kind of benign tumor are more dangerous. The solitary intraductal papillomas are true polyps of epithelial-lined breast ducts. Solitary papillomas are most often located close to the areola and often cause the nipple discharge. Always the discharge is hemorrhagic. The papillomatosis refers to the epithelial hyperplasia, which commonly occurs in younger women or is associated with Fabrocystic change. The two kinds of diseases also different, but they have very similar clinical manifestations: the nipple discharge and the mass if the tumor is too big. And in the ductography, the filling defect will be detected. The treatment, the surgical removal of the whole duct tree where the lesion located, is suggested. While papillomatosis is not composed of true papillomas, but has hyperplastic epithelium that may fill individual ducts like a true polyp, but has no stock of fibrovascular tissue. It is controversial of papilloma's malignant potency, but in my opinion, the multiple papillomas, especially the peripheral papillomas, are more dangerous than solitary intraductal papillomas. This picture showed how we do the operation. We inject of the blue dye into the duct orifice to label the lesion ductal system, and then remove of the whole duct tree. We can see a large tumor, and those are the pathologic section. If there is moderate to severe atypical ductal hyperplasia with multiple papillomas, the risk of breast cancer is high. The prophylactic mastectomy with or without reconstruction is suggestive. And the next step, I'd like to introduce the breastsarcoma. This is not benign tumors. As we know, the sarcoma are malignant tumors, but they are very rare, so I put this content here. But most common breastsarcoma is a special kind of tumor called Phyllodes tumor. They are used to be called as cystosarcoma phyllodes. The name has been changed to Phyllodes tumor in recognition of its usually benign course. It is formed of mixed connective tissue and epithelium. Histologically, these tumors are similar to fibroadenomas, but the hard stroma forms larger clefts lined by epithelium that resemble clusters of leaf-like structures. The stroma is more cellular than a fibroadenoma, but the fibroblastic cells are bled and mitosis are infrequent. It is said, imagine there are two ends. One end is the fibroadenoma, and the other end is the malignant Phyllodes tumors. Most Phyllodes tumors are more closer to fibroadenomas. Their clinical manifestations are firm lobulated mass with rapid growth, and they always larger in size. The average diameters could reach 5 centimeters or more. They are high density in mammogram. And the treatment of the Phyllodes tumor, the benign Phyllodes tumors, the local excision is enough. To the intermediate tumors, also called borderline Phyllodes tumors, they are treated by excision with the margins of at least 1 centimeter to prevent the local recurrence. The malignant Phyllodes tumors are treated similar to soft tissue sarcomas. The complete surgical excision of the entire tumor with the margin of normal tissue is advised. The metastasis of malignant Phyllodes tumors occur via hematogenous spread. The common sites include lung, bone, abdominal viscera, and the mediastinum. The local recurrence most often happened within the first 2 years after excision of Phyllodes tumor, and close follow-up with examination and imaging allows early detection. In this slide, I will introduce the other breastsarcoma, the angiosarcoma, the fabrosarcoma, lymphatic sarcoma, are very rare and arise in younger patients. The treatment includes the surgical excision and the radiation therapy, which could be helpful in the local regional control. On the left hand, this is a Phyllodes tumor, the borderline Phyllodes tumor. You can see the clefts, the leaf-like structure, the clear border. And the picture on the right side is angiosarcoma. It's a very large and aggressive tumor and very poorly differentiated. In general, sarcoma has less favorable prognosis comparing to breast cancer for the lack of the effective systemic therapy. So this is at the end of the section 3, and thank you for your attention.